This is definitely micro. Micrography is when the font size goes down, right? So at first you think my first thought is it's micrography, but if you look at the font size here and here, it's not that much different. You just kind of went in. So with repeated handwriting, one of the first things looking for is enlargement of the handwriting, which is called macrographia, or smaller handwriting, which is called micrographia. But there's other things that we see here. We basically see a decomposition of writing skills. And this can happen when the motor cortex is just not functioning well. Now we know in the brain region localization form that he has symptoms associated with the prefrontal, dorsolateral, orbital frontal that are pretty significant. He's had several traumatic brain injuries. And one of the things you'll see is just this decomposition of movement if areas of the brain are not functioning very well. That might be what's going on. We'll have to see the rest of the examination findings to determine what other neurological findings exist. So we can see that his blood pressure is extremely high for his age. He's 28 years old. His blood pressure is seated as 141/90, and then when he stands up, it's 156/100. So he's clearly in stage 2 hypertension, which is levels above 140, systolic or above 90. So he's right on that early pattern of stage 2, moving into progression of really severe cardiovascular risk. Now, you got to figure, why would a 28-year-old have such severe blood pressure? I mean, there could be genetics involved, but at this point, it's really, really clear that unrelated to anything that's related to his chief complaints, he has serious risk for cardiovascular disease. And if he has this stage 2 hypertension for the next 2 years, 38, 48, he could have severe damage to his vascular endothelium and really set up the stage for atherosclerosis. So just with this finding and his age, I know I want to really do a further evaluation of his blood vascular health. So we want to measure things like homocysteine, C-reactive protein, fibrinogen, TMAO, oxidized LDL, apolipoproteins, matrix metalloprotein enzymes, and the lipoprotein particles. Maybe even red blood cell magnesium, methylmalonic acid, all the things we talk about in the cardiovascular course. We even want to do things like H. pylori testing, since those pathogens have been shown to damage vascular endothelium. We definitely want to do a coronary artery calcium score to see if he has any early stages of atherosclerosis. But this is really a big deal, and we got to try to figure out what the mechanisms could be. Now, when you read his history and you see someone who's got multiple traumatic brain injuries playing football, the possibility of neurogenic hypertension exists. And if it's neurogenic hypertension, we may have to look at improving his brain function and seeing if things change that. But overall, this is a very serious examination finding that cannot be ignored.
I mean, I had like that's where one was. There was kind of one under. You can see that.
It's bruising here too. You had about that.
That
Okay.
It looks like that, but usually a lot worse, and it's bigger.
Okay. Anywhere else?
No, it's usually my hands, but they're clean right now.
Got some stuff here.
Yeah.
Yeah. You noticed?
Yeah, that was itchy a few days ago.
So you get some eczema here too.
Mm-hmm.
You get some calcaneal fissures.
What does that mean?
You have the hardening. You walk barefoot all the time?
Yeah, fair amount.
Okay. Let's take a look at your nail beds. It's nice. So you can see that Toby has atopic dermatitis or eczema throughout his skin, and this is really an indication that his immune system is overactive, right? Whenever you see these inflammatory immune responses, you know that their immune system is upregulated. You're just seeing that expression on their dermal tissue. And then his nail beds, you can see that they're nice and healthy and pink. His capillary refill time is okay, so those are good to see. And we expect to see that just because his blood pressure is pretty high. He's getting a lot of perfusion into those nail beds. Usually when people have low blood pressure, you'll see those white pallid nail beds, and if they don't have enough perfusion, you see that abnormal capillary refill time. But you can see his nail beds are really pink, and his capillary refill time's nice and normal. Yeah, circulation in your legs aren't as good. That's what you noticed when you said you have cold-handed feet.
Both are very cold, like they're cold right now.
Yeah.
My hands are super cold. Well, not as bad as they have been in the past, but pretty bad.
So you're 84. Can you see? Like you're 84 here. Right?
Mm-hmm.
Oh.
74, is that what it says? Is that 67?
67.
Wow.
Was it that different in my hands too?
It's bad. A little bit. It wasn't as bad. You're 88. To 70. Okay.
What is that?
Your pulse ox is 99%. Is pretty good. Your
Oh.
perfusion index
Oh,
is 0.82. That's pretty good.
Oh.
0.9. So we can evaluate circulation by looking at surface temperature, and with the surface thermometer, we can see changes between 12 to 17% difference between proximal to distal tissues, worse than his legs. And normally, you like to see this, ideally even, but even within a 10-degree difference, less than 10-degree difference, that's normal. Now, we have to remember that his blood pressure was in stage 2 hypertension. Now we're seeing signs of really poor circulation. Both of these are red flags that his vascular endothelium is not making enough nitric oxide. So when you don't have enough nitric oxide, you can't produce vasodilating substances, and you end up with really bad circulation, and you end up with hypertension, and then the hypertension continues to damage the vascular endothelium. So we have another red flag for some cardiovascular risk. And remember, he's 28, and we're seeing these poor nitric oxide patterns. And usually nitric oxide levels really start to be significant and drop patterns like this when someone's usually in their 60s. Not to say it's normal, but that's when you typically start to see a lot of these types of patterns. So he's like 30 years early from what we typically see with patients that is the age of they have some injury and damage to the vascular endothelium. I would be worried about what his blood pressure and his vascular function would be 30 years from now. And once again, hopefully he doesn't have any cardiovascular events until then. So his cardiovascular mechanisms are really, really critical, even though it's not part of his chief complaint. At this point, it can't be ignored. Okay, great. We can see that his inner eyelids are nice, pink, and healthy. We're not really concerned with significant anemia unless we see a pallid pattern. Now, when someone has blood pressure issues and circulation issues, and if they had anemia, it would be devastating for any potential to improve their overall health and improve general cognitive and brain functions. Okay, so you just have some decreased pigmentation there?
Yeah, it's since I've been a kid.
Since you've been a kid? It's
Yeah.
nothing new?
No.
Okay. So you can see these areas of hypopigmentation on his skin, and whenever you see that, you have to always rule out that they don't have vitiligo. And with vitiligo, there's an autoimmune response against the melanocytes of the skin that make melanin, and you get those patchy areas of hypopigmentation, and they start to spread throughout the body. And the pattern looks identical to what he has. Now, he has had this since childhood, so he was born with this variant of his skin. But clinically, you should know that it looks just like that. So if you see these patchy areas of hyperpigmentation, especially if they're more developing over time, then you know that they have an underlying autoimmune disease. And once you find one, you find others. Deep breath in and out. Breath in. Go ahead. Just go at your own pace, breathing. But all the way in.
Go.
And all the way out. Deep breath all the way in, all the way out. Deep breath. So in this part of the examination, I'm auscultating his carotid arteries, his thyroid, his heart, and his lungs. Now, just to rule out a couple things. Now, first of all, when I'm seeing high blood pressure like this, I just want to make sure his vascular system is healthy, so there's no bruise over his carotid arteries. And then I listen over his thyroid gland, and if there's any underlying hyperthyroid patterns, hyper being overactive, HYPR, if there's any hyperactive thyroid patterns that can raise blood pressure, but with him we don't see any indications of hyperthyroidism. He's not sweating, his heart rate was fine, and there's no sounds of swishing you would hear with auscultation of the thyroid gland. And then I'm just carefully listening to his heart. I just want to make sure that we don't have any abnormal heart sounds, there's no splits, there's no murmurs, and everything sounds great. And then I'm just carefully listening to his lungs for any wheezes, crackles, rails, rhonchi, echophonia, any of these abnormal pulmonary sounds, and he's fine and totally healthy with these functions. Go ahead and swallow. Okay, so I'm going to stick this. Take a look over here. So in this part of the examination, we're just taking a look at his thyroid gland, palpating his thyroid, and doing a lymph node palpation. And we don't feel any abnormalities with his lymph node palpation. There's no large lymph nodes. And then with thyroid palpation, there's actually no masses or nodules or even any swelling. Now, when you look at his neck, I think a lot of people might be thrown off because he's got such a big Adam's apple or thyroid cartilage, right? So the thyroid cartilage sometimes can be misleading, but remember the thyroid gland is underneath that. And then he also has really big sternocleidomastoid muscles, SCM muscles, because he does weight training. So, a lot of times people look at his neck and go, there's got to be some enlargement there, but there's not really an enlargement of his thyroid gland. It just has really thick thyroid cartilage or very big Adam's apple and really thick SCM muscles. But the actual area of the region where the thyroid gland is, underneath the thyroid cartilage and between the SCM muscles, is totally normal, and there's no abnormal findings with palpation. So you can see that the abdominal reflex is normal on both sides, and the abdominal reflex is activated by just stroking the skin, and you see that umbilicus move to the area where you're stroking. And this is just a test to rule out any types of central or upper motor neuron lesions of the corticospinal tract as it hits the lower thoracic areas like T8, T9, T10, T11, T12. Any kind of injury to those descending motor tracts, things like multiple sclerosis, can injure these areas. And you can also see people have neurogenic bladders where they can't control their bladder tone, may have some abnormal reflexes. Now also remember the majority of people that don't have this reflex sometimes have it because there's just too much body fat, so they really can't even perceive the reflex because of that layer of body fat that's impacting it. And then people who've had like abdominal surgeries like C-sections, or even women that have had multiple pregnancies and have really stretched out these plexus areas, may have an absent abdominal reflex. So by itself, you just can't diagnose an upper motor neuron lesion, but certainly if you see any abnormalities with other upper motor neuron signs, you'd be concerned. Now in his case, everything is normal. So during abdominal auscultation, I'm just listening for bowel sounds, how frequently they occur, and the strength of those bowel sounds. Now, I'm especially concerned about his bowel sounds because he's got chronic gastrointestinal symptoms, and his main complaints are bloating, burping, stomach discomfort. He's had this for a long period of time, and he's done an exhaustive list of protocols and nutraceutical interventions and dietary interventions, and nothing has seemed to make a difference for him. He also has at least 3 different positive SIBO tests, so his gut enteric plexus may not be functioning very well. Now, listening to his abdomen, there really wasn't anything significantly abnormal. Not to say that we heard really great bowel sounds and lots of good frequency of bowel sounds, but it wasn't what you would normally hear when you really suspect that there may be a brain-gut access issue. So it's possible that there may be some issues related to that, but auscultation of the abdomen is limited in showing you those potential patterns unless it's very severe. And in his case, we're not seeing a significant loss of bowel sounds and bowel motility activity. With the ECG or electrocardiogram test, we're looking for to see any abnormalities of any electrical signaling, as you know. And sometimes when people have arrhythmias or abnormal electrical activity from things such as coronary artery disease or enlargement of the heart, you can see some abnormal findings with the ECG. Now with him, everything is normal.
Spell it?
Okay, block one nostril. And the other side. Same?
Wait, do this side again. It's a little less. I think it's the same.
What is it?
Coffee.
Yeah.
Okay.
Other side?
Okay.
Same?
Yeah.
Other side?
Okay.
Same?
Yeah.
Tell me when you can smell it.
Now.
Okay.
Now.
So testing smell is really important, especially with someone who's had multiple traumatic brain injuries. There's always the possibility of post-traumatic anosmia, which basically occurs when the skull's cribriform plate has pieces directly sever the olfactory nerves going to the olfactory bulb. And this can lead to significant loss of smell or permanent loss of smell. Now with him, with his history of head traumas and also the brain region localization form showing the area of deficit is this frontal lobe area, the front of his brain, these types of post-traumatic anosmias can occur. Now with him, we see no signs of that, and his sensory perception of smell is normal. See if the brightness of color is different.
Okay.
Same or different?
I think the same.
Okay. So the Ishihara test is typically done to look for color blindness, but in this case we're just looking at one of the images and I'm having him compare the contrast or brightness of colors from one eye to the other. And this is just a quick screen to see if there's any injury to the occipital lobe. Now, he has no symptoms of that in the brain region localization form, but sometimes when people have injury to their frontal lobe and he has symptoms of that on the questionnaire form, of deficits in the frontal lobe, you get a countercoup, meaning the frontal lobe gets injured, but during that injury it pushes the brain to the back of the skull, and then you can get the back of the brain, either the cerebellum or the occipital lobe, to also be injured. And one of the things you'll see with that is that people will usually have a damage to one side more than another, and then they'll have a discrepancy of color contrast from one side to the other. They'll end up with floaters and other symptoms as well. But in his case, everything was normal. Give you a little tap here. Perfect. Other side. Perfect. Go ahead and wrinkle your forehead. Okay. Blow your cheeks out. Okay. Close your eyes tight. Don't let me open. Okay. Go ahead and open your eyelid. Good. Push your tongue against your cheek. Other side. Open and close your jaw. Open all the way. And close. Okay. So when we go through and test different areas of bulbar function or brainstem function, we start with the corneal reflex. The corneal reflex is touching eyes with this tissue. We activate the V1 sensory distribution of the trigeminal. There's monosynaptic reflex with that, with the cranial nerve 7. Auriculus oculi muscle, we get a contraction there, and we know that sensory motor loop is intact. And then we just have him wrinkle his facial muscles, his cheek, and we see that cranial nerve 7 is intact. Then I have him close his eyes really, really tight, and then try to open him. That can give me a better assessment of his auriculus oculi muscle innervated by cranial nerve 7 to make sure that everything there is intact. And then I put my hands on his eyelids and have him lift his eyelids. And that's really the levator palpebral muscle, which is innervated by cranial nerve 3, and those are intact. Then I have him push his tongue against his cheek and check the strength on one side to the other. And we can see that there's equal strength on both sides. And then I have him open and close his jaw just to look at his motor function of his trigeminal motor nuclei. And everything is intact. Do they feel eyes open? Do they feel the same, right to left?
Yeah. Mm-hmm.
Okay.
Same. 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 Sit.
Same.
Mm-hmm. Sit. I think so. Mm-hmm.
Put your fingers in here.
Mm-hmm. Same. 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 Same.
Okay, this is number 1.
Mhm.
That's number 2. Which one's cooler?
Ooh.
Here's 1. Here's 2.
I really don't know. 1 maybe?
Okay, let's try up here. Here's 1.
Uh-huh.
Here's 2.
1.
Here's 1. Here's 2.
1.
Here's 1. Here's 2.
1, I think.
You think?
I think so.
How about here?
I
Can't.
don't know. Well, that one for sure.
Okay, so difficult in here. Palm, like your palm.
Yeah.
Okay, here's 1.
Mm-hmm.
This is 2.
1.
Here's 1. Here's 2.
2.
Here's 1. Here's 2.
2.
Get some positive Blanche test.
What's the, oh, to the stuff?
Okay, here's 1. Here's 2.
2? I can't really tell.
Okay, how about here? Here's 1. Here's 2.
1.
Here's 1. Here's 2.
1.
Here's 1. Here's 2.
1.
Here's 1. Here's 2.
I have no idea.
Here's 1. Here's 2.
Yeah, I don't know.
Here's 1. Here's 2.
1.
Here's 1. Here's 2.
1. Now. 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 Battery, but I may have seen the packets
That's
in
okay. As long as you feel it. Close your eyes.
Paperclip.
That's fine. Great.
2.
Which one am I touching?
3.
Don't move your hands at all. Which one on the right?
The right, my right hand or your right hand?
Your right hand.
My right hand is 2.
Which one on the left?
3.
Okay, great. Okay, I'm going to draw something on your hand. Tell me what letter it is.
I think it was O.
Okay.
T.
So evaluating sensory perception is really important. We know that sensory perception involves peripheral nerves and also the brain, specifically the parietal lobe or the somatosensory cortex, and has a homunculus distribution. Now, whenever we see any type of deficit on one entire limb, one entire region of a limb, we start to suspect that the contralateral parietal lobe may be involved, may have some type of injury. Now, with him, with his history of so many traumatic brain injuries playing football, and also with clear indications that he's had some frontal lobe injury, right behind the frontal lobe to the side is the parietal lobe. And, carefully evaluating sensory function is really important. Now, also, if someone has any kind of sensory loss in one limb, and especially if it's in a specific area of the limb itself, you always have to make sure it's not a radiculopathy like a C5, C6, C7, T1 distribution, which will come typically from some kind of occlusion, a compression on the cervical nerves or lumbar nerves coming out of the spine. And then we always want to rule out for any types of peripheral mononeuropathies, things like glove and hand distribution, like diabetic polyneuropathy, or mononeuropathies like a median nerve entrapment or a peroneal nerve entrapment, or any kind of peripheral nerve injury. And with them, we can see that there's no abnormal sensation, perceptions with light touch or pinprick sensation or vibrations. Now, there are some differences in efficiency with his ability to distinguish temperature, but since his circulation is 12 to 70 degree difference and his feet are so cold, this body temperature being so cold in those distal tissues already starts to depolarize some of these temperature receptors, so you can't tell the difference between cold and hot. It's not due to nerve injury, it's just due to depolarization of those thermoreceptors. And it's really also important to note that even within the parietal lobe itself, there's different cells for vibration sense perception, there's different cells in the parietal lobe for temperature perception and so forth. But in this case, we don't see any kind of abnormalities. The monofilament test, just a quick screen for any kind of polyneuropathy in the feet. You see that all the time with diabetics. His were intact. And then when you look at stereognosis, he was able to perceive the objects in his hand. Extinction is a really more complicated test to evaluate parietal lobe integrity, to feel the differences between which finger is being touched when they're both being touched at the same time. And then graphesthesia, the ability to understand what numbers are being written. So we see that we have a pretty healthy peripheral sensory system and healthy parietal lobes with Toby. You close your eyes and visualize your left knee, and visualize your right knee. They feel as easy as perceived from left to right.
Yeah.
Okay, how about your elbows, left and right elbows?
I mean, maybe right's a little slightly harder for both of them. How detailed?
Well, it's hard. I mean, it's your perception, so tell me what you're perceiving.
It just feels a little bit harder to find the right one.
Really?
Yeah.
Compared to your left?
Uh-huh. Left is like immediate, right's like, it takes a split second.
Okay. Let's try your ankles. Right and left ankles.
Yeah, it's the same.
Same?
Mm-hmm.
How about your big toes?
Yeah, same.
Same?
Yeah, I didn't know where spaced the big toe was at first. I can't feel that as well.
Okay. How about your hips?
Yeah, just a little bit different.
Okay. How about your thumbs?
Those seem fine.
Fine.
Yeah.
How about your eyelids?
The same.
Okay. But you did notice in your elbows, yeah?
Yeah, well, I did start left to right, so should I try right to left
Sure.
first? Yeah, actually, that's what was happening. It's just when I started with, I think, because I did them all like that.
Don't talk yourself out of it. Let's make sure.
Well, I don't really know.
Let's start with your big toes.
Okay.
Go
all
in
right.
the opposite order.
Okay. They seem like the same there.
Okay. And let's do your kneecaps.
Okay. Yeah, so the right, it's whatever I do first is easier to find, then the second one takes like a split second after. It's like weird.
But you can perceive it.
I can, it just takes like
It's just
a little
bit
longer.
of delay.
Yeah.
Okay. Same with your thumbs,
Yeah.
then your elbows.
Yeah, I think there's a little delay.
Let's switch back the other way.
Okay.
Tell me if you start with your toes.
Toes. Yeah, just a tiny little split difference.
Whatever second.
What's that?
Whatever you do second is a little bit harder.
Yeah. Mm-hmm.
Okay. And as part of the test, we're evaluating visual perception of the body. So we're asking the patient to compare the ability to perceive various body parts from the left and the right side. And he has some difficulty with body perception with the right and left, independent of the side, but specific to like the initial side. And, you know, when you see this, one of the first things you always worry about is if the parietal lobe is healthy or unhealthy. But with him, if you remember, his sensory perception was really efficient. Now, this test is primarily a somatosensory evaluation, the ability to sense soma being muscles, joints, and ligaments. So the somatosensory cortex perceive these areas. But with him, it's very likely that his inefficiency with this test is really more so associated with just the cortical function of attention and not necessarily associated with parietal lobe perception. So you need to have a lot of attention to one specific region in order to be able to properly perceive that body part. So we know that these findings are there, but more than likely that they're really associated with cortical attention issues that can take place when the frontal lobe is not functioning so well. And we see lots of symptoms of that on the brain region localization form. So you get a little bit of eye deviation there and a little bit of a head tilt. I'll check that later. Okay. With the corneal light reflex, you basically shine a light directly in front of their face, and you see where the light hits their cornea, and they should be exactly in the same location. Now, with Toby, we see a little bit of head tilt, but unrelated to the head tilt, we can see that he's got a hypertropia, meaning one eye is elevated than the other eye, and it appears that his left eye is higher than his right eye. Maybe easier for you if you pause the image, you can see it more clearly, but this suggests a possibility of any type of eye muscle weakness, but that needs to be further evaluated. This is just a screening test to determine if that possibility may exist. Okay. The nasal septum evaluation is something you should always do when you suspect someone has had multiple injuries, especially to the front of their head, front of their face, which Toby has a history of. And there's times where people have actually broken their nose and deviated their septum and have some kind of injury from trauma, and they're not really aware of it. They kind of just get used to it. Now with him, we see no abnormal deviations of the septum that indicate those findings. Stick your tongue out. That's a good saliva there. Say ah.
Ah.
Relax. Relax. And ah again.
Ah.
Ah again.
Ah.
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 Again. Ah.
Ah.
Okay. Ah.
Ah.
Should be going up. Ah.
Ah.
There we go. A little better there. Ah.
Ah.
Oh, there we go. Ah.
Ah.
And then relax. Relax. There you go. Oh, you weren't relaxing before.
Ah.
Okay. Let's say ah.
Ah.
And relax. Relax. And ah.
Ah.
And again.
Ah.
Yeah. Ah.
Ah.
Relax. Ah.
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 Relax. Ah.
Ah.
And again.
Ah.
And again.
Ah.
Okay, check your gag reflex. So with examination of his mouth, we don't see any kind of lesions or ulcers or any kind of discoloration or signs of unhealthy gums or gingivitis. Everything looks great there. We see nice pink color, and we also see that it's shiny. Shiny means there's lots of saliva. So we can see that he's producing saliva out of those glands, and that's a really good sign of some parasympathetic activity that's occurring. Then we go through and check his palate, and his palate responses are moving, but they're what we would consider sluggish. We don't see these dynamic jumps and dynamic movements that are there. Then I do some repeat testing. Try to have him relax to see if his palate will just drop and go down. And basically, only when he stops breathing and changes position of his windpipe do we see the palate move down. But technically what you're really seeing is this palate just isn't moving much, very high. So this makes us suspect that he may have some brain-gut axis issues with his brain history and this pattern of chronic gastrointestinal issues, especially since he's done so many things for his GI tract and nothing's really responded. And these vagal pathways that control the gag reflex are really critical for activating the enteric nervous system. And when that's not working, you can get patterns of SIBO. So we're starting to suspect that he may have some brain-gut axis issues. And maybe part of the reason he has some chronic gastrointestinal issues is some of these traumatic brain injuries he may have had. So the possibility or the working diagnosis of potential brain-gut axis issue is now something to consider. And his gag reflex are intact in both sides, but also again sluggish. Wow, nice. With endoscopy, we see really healthy structures of the retina and the blood vessels around those regions. His optic cup was healthy, his optic disc was healthy, his retinal veins and arteries were fine. There's no abnormalities or changes in his macula and fovea, and just a nice healthy color. So we're seeing really healthy structures of the retina. Ooh, look at that nice brightness.
What's that?
That's nice.
What is
That
that?
nice glow.
And what
Because
means?
your sinuses are not
Clogged?
congested here. Open your mouth. And then we're gonna go right in here. Yeah. Great. And the other side here. Open your mouth wide. Nice. Okay. We can see really nice illumination of his sinus cavities with the light. They're equal on both sides, so we see no signs of sinus congestion. Okay, we're just going to check your reflexes. Okay. Get it. Ooh! Big arm. G-trunk. Lay this in here. Just gonna check your jaw reflex. Let your jaw relax. Just gonna check your rooting reflex.
Your face is really
Yeah, that was fresh.
Let your hands rest here. Just gonna stretch your foot. So in this part of the exam, we're just evaluating the motor system. We start with muscle tone evaluation. Remember that with muscle tone, if you see tightness or spasticity, you can potentially have any injuries to the motor strip all the way down to the corticospinal tract. If you see rigidity or stiffness, you worry about the basic angular tract pathway or Parkinsonian type patterns. If you see like loss of tone altogether, or hypotonia, you see that with cerebellar injuries, and with him, his tone is nice and normal. His deep tendon reflexes are all intact in his limbs and his jaw. Then I go and percuss his hypothenar area to see if we see any myoclonic activity. You can see that for a number of disorders, but with him, his were normal. Then I go through and do some upper motor neuron testing to evaluate any kind of potential lesions that may be occurring anywhere in the brain, all the way down to the cord level. Start with his rooting reflex. I just stroke his skin around his cheek to see if he has his lips move. This is also a primitive reflex we typically find abnormal with childhood developmental disorders or any kind of delay in this frontal lobe corticospinal pathways. I go through and do palmar stroking, plantar stroking, looking for any types of jerks or movements like a Babinski. And then I check for any upper motor neuron lesions from the cervical cord up by flicking his fingers with Chalmers and Hoffman's. And then we go down to Gordon, squeeze his calf to see if we see any toe flaring or Babinski signs. Then I do a quick stretch to see if we see any kind of clonus. And everything here is nice and healthy, so we see no indications of any disease to the motor system and no signs of any kind of neurodegenerative diseases that may be involved. But we wouldn't expect that with his age group, but sometimes you do have early onset Parkinsonian patterns in the 35 or even early 30 age group, but with him everything is intact. Other side. Same time, one more time, but some eyes closed.
Eyes closed. Okay.
Heel to shin testing is done to evaluate function of the cerebellum as it coordinates and calibrates muscles turning on and off in sequence. Also with targeting of the lower extremity, and with him we see a normal response. He's able to target his kneecap and then go down his shin in a smooth manner. As fast as you can, all the way open, all the way close. Hand straight out. Play the piano as fast as you can. Okay. Okay, just the right side. Just the left side. Okay. One at a time. Faster. Faster. Pretty good. Hands out like this. Play the piano. Okay, we can see with rapid motor testing, whether it's finger to finger or playing the piano or tapping his feet, that they are very efficient. They are coordinated very well, and the speed is very good. So whenever you do rapid motor testing, you want to first of all see if there's any difficulty with conducting the motor test from a coordination point of view. And if you see any of those things, it's called dyspraxia. So they have a hard time maybe going finger to thumb or figuring out how to do it, or they use the wrong finger, or you haven't tried to play the piano, they have a really hard time with coordinating, initiating that task. Those are involved with the premotor area of the frontal lobe. And then if you see any issues with speed, like just slowness, you see that with injury to the basal ganglionic pathway or early Parkinsonian patterns. And all of his rapid motor testing was very good. Touch your nose with this finger. Do this one. This one. This one. So with cardinal fields of gaze, we're just having him track our finger in a X and plus sign pattern, and we're looking just for smoothness of movements, or a sign that the eyes are tracking very well. And eye tracking involves cranial nerves 3, 4, and 6. They're coordinating those in the motor areas of the brain stem, and also involves different regions of the brain, like the frontal eye fields and areas of the cerebellum. And if anyone has any history of brain injury, it's something you want to check. And also, if you see any kind of abnormalities of eye misalignment at the very end of range, you might see like a double vision. And with him, everything is intact. Cover and cover tests were just not allowing the brain to be able to use both eyes for vision. So if there's any kind of eye weakness when one eye is covered, it's normally compensating. It'll show up when you uncover the eye. And with him, everything is normal. There's the initial thought that there may be one abnormality when we uncover the left eye, but what's really occurring is that he was gazing to a different direction right before we did that test, and then we uncovered it. There was a slight movement, but it was really a false test. Overall, he has no abnormal cover-on-cover test results. This way. Okay, now when you see this one move, which is look at that's target.
Wait, what was that?
If you see this move, which is focus on that target as fast as you can. Then come back to center. Then if you see this move, focus on the other one.
And then go back to center?
Mm-hmm.
Okay.
One more time. Okay. Then go back and forth as fast as you can. Visual saccades are just quick targeting of the eyes. And if you're working with patients that have autoimmunity, multiple sclerosis, head trauma, child developmental disorders, you definitely want to start testing eyes and different types of movements. Now the saccades are pretty easy. You just put your fingers out. You have them target left and right as fast as they can. Now the speed of their eye movements to one side is the frontal eye field. The accuracy of them to be able to target without overshooting or undershooting the target, meaning getting to the target and then readjusting before they get to it, or passing the target and then readjusting back. Those are called hypometric saccades, meaning if they're undershooting, hypometric, if they're overshooting, hyper, and those are seen with cerebellar dysfunction. Now with him, we can see that his saccades are healthy, there's no overshooting, undershooting, the speed between both sides are good, so that lets us know that, even though he's had multiple head traumas, we don't see any significant injury in those frontal eye fields or regions of that cerebellum, and specifically the midline cerebellum. And then I have him do what I call anti-saccades, so I wiggle my finger when I wiggle my right finger, track to the left finger as fast as you can. If I wiggle my left finger, track to the right, so they go opposite of where the visual stimulation is. And those will happen with the frontal eye fields, but integrating with focus and attention of the frontal lobe. And people that have frontal lobe injuries sometimes will have a hard time with these anti-saccades, because when they see a finger move, they want to track right to it instead of going to the opposite side. Now with him, everything was intact. Optokinetic tape testing has a person look at a tape with red and white stripes, and then they move it across the visual field, left to right to left, up to down, or down to up. What you're looking for is those, saccadic type movements, slow tracking to one side, like following, let's say, a red line, and then seeing the next red line, and then saccading or quickly going back to the other side. And if people have any kind of like injury to their vestibular system, cerebellar system, many times when you do this test, they get nauseous. It really is very stimulating for them. It feels like they're spinning or moving. So sometimes you see those responses. But also when doing optokinetic, you just want to see if those eye movements are the same between one side and the other, and it doesn't cause any symptoms. And these are really looking at areas of the frontal eye fields, the right inferior vestibular cortex, but just different regions of the brain. And even if you don't really fine-tune specific neurology, if you're working with people that have had head traumas or demyelination or autoimmunity, if you just see that they're off and one side's worse than another, or you get symptoms from it, it's something you can keep in a baseline from your exam findings, and retest them as you're doing different protocols and see if maybe they're having equal speed and responses to one side to the other, and they're not, or for some people, if they were getting symptoms of dizziness and movement, when you move that tape across, that just stops happening. That'll give you clues that their brain is getting healthier. Now with him, his optokinetic tape functions were totally within normal limits, and very efficient from both right to left, and also they're very efficient from up and down vertical pathway. Then we're going to do a head impulse test. So I'm going to move your head quickly.
Okay.
So the vestibulocular reflexes are organized in such ways that when your head moves to one side, your eyes shift to the other side. And that happens so you don't lose and fall off an image when you move your head. Now, some people that have injury to the back of their brain or have any kind of problems with their inner ear vestibular system will have some abnormal vestibular ocular reflexes. The way you test is basically you have them look straight ahead at a target, for example, between your eyebrows. You slowly move their head to the left, to the right. If their head moves to the left, their eyes should go to the right. If their head moves to the right, the eyes should go to the left. If you go up, the eyes should go down. If you move the hand down, the eyes should go up. If you move the head up to the right, the eyes should go down to the left. And then you're going through and just checking all the different vestibular pathways or just different directions and making sure they're intact. Now sometimes when you do it, some people have symptoms. That'll be a red flag. Sometimes people get dizzy. Other times you just won't see the eyes move as well. And then the other thing that sometimes occurs is when you're doing these vestibulocular reflexes, You'll see a little bit of bouncing nystagmus at end stage, or you might see the eyes not track equally from right to left. It's kind of like a dysconjugate pattern. You'll see that with multiple sclerosis or demyelination that starts to impact some of these centers in the upper brainstem. Now with him, everything was normal with the vestibulocaudal reflex. And then the last thing we did here is the head impulse test. The head impulse test is also called the Halmagyi maneuver, but basically you turn the head slowly to one direction, let's say the left, and then you quickly bring the head back to center, and the eye should just come back right away to center and not bounce around. If you see any kind of bouncing, that's a positive sign, and that's an indication that there's something wrong with the vestibular or cerebellar structures of the brain. So with visual convergence, you want to see the eyes converge together. You also want to see the pupils constrict. His convergence and pupil constriction or accommodation were normal. Open the whole time?
Mm-hmm.
Any dizziness or symptoms?
No.
Okay. Any dizziness or symptoms?
No.
So here we can see the Dick-Hall-Pike maneuver being done with Fresnel goggles. The Fresnel goggles prevent any kind of visual fixation. During the test, we bring the patient's head back into extension and rotation to the left side, and then extension and rotation to the right side. That puts the head in a position to have any dislodged crystals move up the posterior canal, and if there's any kind of abnormality, you'll see like a diagonal type nystagmus, where they have a slow phase down and then a fast phase up at a diagonal plane. And then they usually feel symptoms of nausea, they can start sweating and having all those problems. With him, the Dick-Hall-Pike maneuver is normal. Just keep walking. Keep going. Tell me when you walk back this time, do every other letter of the alphabet out loud as you walk.
Every other letter.
A, C,
Okay. A, C, E, I, L, O, Q, S,
Start again. Start with B.
B, D, F, H, A, J, L, O, Q,
Okay, start with A.
A, C, E.
Okay, and just walk normal.
Okay. Yeah. We're still talking?
Just normal. Just normal.
Okay.
Just walk.
Okay. That was tough.
Okay, great. Subtract sevens from 103.
103? The hardest thing.
Too smart.
103, 94, 87, 80, 73, 64, 60, wait, 65, 60, I don't know, I lost track. To keep going.
Yeah, it's okay. You're good. So with gait analysis, you can see that Toby doesn't have the smoothest gait. However, everything is fairly normal. He has good arm swing, right and left. He has a good leg swing. He's not shifting to the left or right when he walks. You don't have any significant slamming of the foot or shifts of the hip when he walks. So he pretty much has a normal gait. Now, everything changes when we have him double task. When we double task, you can see that his arm swing are significantly reduced, and even at times there is no arm swing. And we have him do double tasking with the alphabet. We also have him do double tasking with numbers, and they both have a significant impact on his frontal lobe. Frontal lobe is involved with those nice arm swings. And then we also see that his speed is impacted with the double tasking. Ideally, you should be able to, go say out loud every other letter of the alphabet and not have any changes in how you walk. But if your frontal lobe and your executive functions and those prefrontal pathways are not functioning so well, then you can see these loss of arm swings and this slowing pattern that's involved. And this is important for us because we see that from his history that these frontal lobe patterns may be involved, and these starting to suggest to us that he may have, this frontal lobe injury, these brain injuries. His palate pathways are a little bit sluggish, and this all starts to go into that potential brain-gut access mechanism. But we know we'll have to see how he responds with various interventions and protocols, and if there's anything else going on with the exam. You feel stable? Close your eyes. Perfect. Open your eyes.
Mm-hmm.
Put one foot in front of the other.
Okay.
And close your eyes. Okay, eyes open.
Mm-hmm.
Bring your feet the other way. Okay, you're advanced, but
Wait, is that what you meant?
that's good. That's good.
What?
Close your eyes. Ready? Okay, that's pretty good. Come on back a couple steps. Okay, I want you to walk heel toe forward, eyes open.
Okay.
Keep your head straight. And then slower. Close your eyes. So test for stability involve having a person stand straight with feet together like a Romberg test, eyes open, eyes closed. They can stand on one foot, right and left. They can put one foot in front of the other like a tandem stance, and that stresses out the vestibular system more. And you can see with Toby, everything is pretty good. His stability and his balance are very good. And then he has no signs of ataxia when he walks in a straight line. Even with his eyes closed, he's able to walk without any major shifts or tilts of his trunk and his body when he's walking. And these all indicate that his vestibular system is intact, his cerebellum is intact, and he has no issues with proprioceptive input coming from his feet. We already did a monofilament test and did some sensory testing throughout his lower feet, and all these indicate to us that these structures are nice and healthy. Elbows in.
Wait.
Like this.
Oh.
And do it again. Fast you can. Hands straight out. And more fast you can. Perfect. So rapid supination pronation is the classical test to evaluate cerebellar function. The cerebellum calibrates turning muscles on and off. And when people have problems with this, you'll see that one side it just doesn't move as efficiently and smooth as the other side. Or you just see like the arms just shift to one side with gross big movements and the other side's fine-tuned and small when they do supination pronation. And with them, we can see that a supination pronation tests are nice, smooth, and have very good speed on both sides.
Yeah.
Okay. Look at the top of your head. Tell me if you hear it equally or more in one ear.
Okay. More on the left for sure. Left, definitely.
Left.
Yeah, wait.
Does that bother you?
No.
Okay, good. Which one's louder? This is number 1, and that's number 2.
2.
That's number 1, that's number 2.
Oh, wow, I can't even. That's
It's 1, that's 2.
good. 2's louder.
Okay. 1,
2.
1.
2.
During this part of the test, we evaluate his hearing. I just rub my fingers together with gross hearing. Those are intact. And then we do Weber's test. With Weber's test, we have some lateralization to the left, which could mean he's got a conduction hearing loss on the left or a sensory hearing loss on the right. And when we go through and do Ryan's test, we see that there's no indications of conductive hearing loss. So there may be a possibility of a right-sided sensory neural hearing loss, and we'll have to do audiometric evaluation to determine if there's any problems with that. We also want to take a look at his ears and his eardrums and make sure that those are nice and healthy, and do tympanometry to see if his eardrums are moving now that we see a little bit of discrepancy with his lateralization with Weber's. Your eardrums are nice and... There we go. With the tympanometry assessment, we use the instrument which has sound waves hit his ear and then look at the amount of movement or flexibility. And when you look at the results on the instrument, you can see that peak triangle shape movement, which is his eardrum. And as long as it's in that square, then we have a normal moving eardrum. If people that have ear infections, you see reduced eardrum movement. People that have scarring of the eardrum, you see reduced movement. And then that triangle doesn't have as much of a peak. Now with him, we see symmetrical, healthy movement of his eardrum, so we're not concerned about that being a factor in any type of hearing loss. You're so clean. Your eardrums are so clean.
Really?
Do you wax
No, I mean,
your eardrums?
usually no. I did once like a couple weeks ago.
So with otoscopy, I'm just looking inside the ear, looking at the tympanic membrane, making sure he's got a cone of light, and really just looking at healthy white pinkett structures of the eardrum, make sure there's no holes in there, make sure there's no signs of scarring, and everything looks great with both tympanic membranes. That's pretty good. Okay, with audiometry, what we're doing is we're measuring different frequencies or pitches. The frequency starting from 500 all the way up to 8,000 hertz. And then we want to see at which decibels can the person perceive those different frequencies. And we want the hearing to be perceived in that 25 decibel area. Now with him, we can see that his hearing on both the left and right were totally within normal limits. So even though we saw some lateralization with Weber's, we really see no indications of any kind of conductive hearing loss or sensory hearing loss. And just for various reasons, sometimes people have lateralization with Weber's test. Sometimes the side you hit the tuning fork could be louder than the other side, and it could lateralize that side. And other times it's just a functional imbalance. You could have greater activation of depolarization in one temporal auditory cortex versus another. But at this point, we confirmed that there's actually no hearing loss through the battery of tests that were just completed. These pupils are good. And with light, they constrict. And yeah. So in darkness, you can see them dilate, right? When the light's on, they should constrict and stay smaller. They go right back to dilating if we turn the lights off. So you have dilated pupils.
Yeah.
Yeah. Might be worse probably when you have like Olympic.
Huh.
Oh, let's check your hair for a second. Just move you so you don't see your eyes. So this light's off. Lights on, and then back into dilation. Yep, you get dilated pupils. To really evaluate pupil function, you really have the best window of seeing any kind of changes when you use these infrared cameras on the eyes and then turn the lights off and on. Now, obviously when you use a pin light for direct and indirect responses to light, you can see the pupils respond. But one of the key things you can see here is that when we have him in darkness, his eyes are dilated. then when we have the lights turn on, we still have some dilation. And then from light to dark, his eyes should dilate, but his eyes are already dilated, so we don't see much of a change in the diameter of his eyes when we go from light to dark. Now, this is really an indication of increased sympathetic response. When you get into a fight or flight response or sympathetic response, your eyes have to dilate so you can see more of the environment, so you can identify as much danger and threats to you as possible. And we know that when he basically works too long, he gets limbic, he gets really angry, he gets really agitated, and we may be seeing some of those expressions now, because we're probably 3 hours into the history and exam at this point, even though we're not seeing every single part of the exam. And we're about 3 hours into this, and he's getting a little bit tired. And usually with people that have brain injuries or are very tired or poor brain endurance, you'll start to see when they get tired, some of their clinical expressions come out more. But then we're starting to see these autonomic changes, these dilated pupils. Now, being in a sympathetic response, if the brain doesn't have endurance and you get into a sympathetic response, because the brain gates the sympathetic pathways of the sympathetic chain, being in that chronic stage all the time can dampen parasympathetic activity. This may be contributing to potentially his chronic gut issues. So it's not just the vagus nerve that may not be activating, but this dysautonomia pattern that takes place when a person may have had brain injury where their eyes are dilated all the time and they're in a sympathetic response, meaning a circulating catecholamines, epinephrine and norepinephrine are much higher, and that will have a suppressive impacts on gastrointestinal motility, enzyme production, blood flow to the gut, and those various mechanisms that are so critical for developing a healthy microbiome and environment for the gut. Just your blood pressure. So pupils do respond to light. But barely. Wow, look at that. Let me use a pen light. Okay, we're going to shine the light in here. Shine the light in. Respond. Shine the light in here. Yeah. Okay, things are working. It just should get dilated pupils. Go ahead and stick your thumb out. Bring that towards your nose. Bring it out. Perfect. Let that relax. Look to the right.
Oh, I did what's
That's okay.
to the right?
Yep.
Okay.
Look to the left. Look up. Look down. Look straight. And turn your head to the left. Turn your head to the right. I'm going to bring your head into extension. Bring your head into flexion. Okay. I'm going to move you back and forth in the chair.
Okay.
I'm just going to see you turning you to the left. Nice reflexes. Turning you to the right. Nice reflexes. We're going to do the same thing with your eyes open.
Okay.
It'll be a little bit faster with your eye movements. There we go. It's the left vestibulocular reflex. It's turning you to the right. That's the right vestibulocular reflex. Go ahead and stare at your thumb. Keep your eye right on there.
Okay.
Keep focusing and moving into the left. Keep focusing. And moving to the right. Keep focusing. Perfect. Stop. I'm just going to clap next to your ear. And just compress your ear. Okay. Your eyes are already dilated. I'm going to pinch you anyway, see if they dilate more. Yeah. So abnormal pupil responses, and especially people who are afferent defects, are classical with any kind of neuroinflammation or demyelination of those optic autonomic pathways. Now with him, he does have a proper direct and consensual response to light. They're just a little difficult to see since his eyes are dilated. I checked his direct and indirect light responses earlier with the pen light, and everything was intact. But now we see a little bit more exhaustion. We're also using equipment so we can see his pupils better. And I start to then just bring in a light instead of just moving the flaps of the lens so light can come into his eyes and initiate the reflexes, which is normally all you need. But with him, since his eyes were dilated, I brought in a light source just to make sure that they're working, and they are responding directly and indirectly. 4, 5, 6, 7, 8, 9, 10, and look straight ahead. Feel any movement or anything?
No.
Yeah. Okay. So we can see when we have him track his finger with his arm extended towards his nose, his eyes converge properly and they constrict or accommodate.